All about empowering, educating and giving space to black people so our communities can look after themselves better. Every Saturday, our black GPs or consultants present on those health and well-being topics that affect you, your family members and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell, and many more. We have not forgotten to include within our health hours the many societal, cultural, religious, and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences, and ask questions to our black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our black community. To request any particular topic, please email health@carn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.
Good morning, everybody. Good morning. And apologies for the slight delay in the opening of the room. Welcome to another CATHIP Health Hour. My name is Dr. Ayo Olatoye. I am an acute medical physician, and I'm a proud partner of CARN. And you're in for another fantastic, another great time. We're going to have a conversation with Dr. Michael Idoye, who is, let me just get his bio up, who is a medical doctor, a geriatrician, that's somebody who deals with older people, an ortho-geriatrician, that's somebody who has expertise in dealing with old people and people who have had bone problems like fractures and stuff, because dealing with fractures in an older person is a slightly different specialty. And that his medical training in both Nigeria and the UK. He is currently working at King's Mill Hospital in Sutton and Ashfield, Mansfield and Nottinghamshire. And if that wasn't enough, he's a pastor of the Mandate Church in Manchester. He's a preacher, teacher, mentor, and counselor. And all those things he does in his spare time, because when he's not doing that, he's married and has children. So we are very privileged. And before I bring in Dr. Idoye, I want to say that these sessions are brought to you in partnership with RAFA International Academy, Croydon BME, Enfield Caribbean Association, the Royal Academy, the Royal Assembly Sheffield, RCCG Church, Black Health Initiative, and obviously the Caribbean and African Health Network. We are so grateful to our partners for helping us doing this, and we're so grateful for you. These sessions are for you, but without you, we would just be talking to ourselves. So thank you very much for logging on. And without further ado, I want to welcome Dr. Michael Isioma Idoye to take this meeting. Thank you so much, Dr. Idoye.
Thank you very much, Dr. Ayo. Once again, I'm glad that a few people have joined us. So far, I can count 60 something. Thank God for that. So today we'll be talking on a topic titled osteoporosis. And next slide, which is the first slide, apart from the introductory slide. What is osteoporosis? Osteoporosis is a bone condition that is characterized by weakness and fragility of the bones. Yeah, that's the next one. Yeah. So weak and fragile bones that break very easily. It develops very slowly over several years and is often only diagnosed when there is a fall or sudden impact that would not ordinarily cause a bone to break or cause a fracture. And such minimal impact leads to a break. So usually in a healthy person, such impacts should not cause any fracture. It is a silent and quiet disease, and it's usually painless until a bone is broken. And that is when it becomes painful. Now, we've talked about the impact, the level of trauma that is considered minimal. And the World Health Organization describes that impact as the impact you have when you fall from a height that is equal or less than a person's standing height. So when you fall from your height, your standing height, for a normal person, you should not break your bones. Any broken bones you have due to a fall that is at that level, and like we said from the introduction, no impact at all, no trauma at all, becomes a fragility fracture, and osteoporosis is the very likely cause. Now, the common sites of fractures are the hip, the spine, and the wrist. I hope and I think many of us would reflect and remember that you've seen older people. For those of us that had the privilege of seeing our grannies and all that, looking a bit bent over and have lost some centimeters in their height. So osteoporosis is most likely the cause of that, even if it wasn't diagnosed then. The problem with osteoporosis is because it is silent until a bone is broken, it is most times not diagnosed until a bone is broken. And once a bone is broken, there are a lot of other things that goes with that. It's not just the bone that is broken. There is associated chronic pain, associated debilitation, and of course, loss of independence and a reduced quality of life. It has a financial burden as well, financial burden on families, financial burden on the system, and could eventually lead to death. Next slide, please. How common is osteoporosis? In women, postmenopausal, around the age of 75 and above, it is 1 in 2. So 50% of all women above the age of 75, postmenopausal, we have osteoporosis. 1 in 5, which is 20% of all men, we have osteoporosis. And by the time you are aged above 75 years, it becomes 1 in 3. We will see the reason why that is later on. Osteoporosis is responsible. Fragility fractures is responsible for over 500,000 attendances in the UK in the year, and 2/3 of that number is due to osteoporosis. Its financial cost on the NHS is about 1.7 billion pounds per year. There are over 3 million people living with osteoporosis in the UK. And in the EU, there are over 22 million women and 5.5 million men living with osteoporosis. And that results in 3.5 million new fragility fractures, that is, fractures that occur with minimal or no impact at all, no trauma at all. In the US, over 25 million people are living with osteoporosis, and osteoporosis is responsible for over 1.5 million fractures in the US. Next slide. Let's talk a bit about bone physiology. Bone has two parts to it. The outer, which is the cortex, which is the compact portion of the bone. And of course, if you are familiar with X-rays, you see your X-ray, that's the part that looks very white. And there is also the central or the inner part of the bone that looks a bit meshy. It looks a bit meshy, and that is called the trabecula. Now, that part of the bone is just like the rack that has been in the news recently. I don't know how many of us have heard about rack with regards to the school and the collapsing buildings. If you have followed the news in the last few days, I'm sure you would have seen or heard about rack. Rack is reinforced, autoclaved, aerated concrete, which has similar shape and pattern as the trabecular bone. And it's interesting, there's so much relationship between the rack and how much that rack needs to be treated to make sure it doesn't begin to fall apart and begin to fail. And it's so related to osteoporosis. Now, many things affect bone formation. From the time you're born, your bones begin to, you're born with very soft part of your bone, the cartilages and all that. And as you begin to grow, have the necessary nutrients and all that, and the hormones, the necessary medication, your bones begin to form and begin to harden and begin to now form these clear parts. You begin to build bones until the peak time or age of about 25 to 30. And thereafter, we begin to lose bones. And our bone mass begins to reduce. That is natural and normal physiology until menopause. Yeah. And the rate of loss usually is not that very significant. But with menopause, there's an acceleration of the rate of breakdown. And post-menopause, we begin to lose bone mass by about 2% per year. How do you classify osteoporosis? Next slide, please. How do you classify osteoporosis? There is a primary classification. There are a few classifications anyway, but we'll talk about the primary and the secondary classification of osteoporosis. The primary is the most common, and it's further divided into two types, type 1 and type 2. Type 1 is the one that is actually most common, is postmenopausal, is found in women that have passed the age of menopause, and is associated with the reduced levels of estrogen, that's the female hormone, and androgen, the male hormone. It leads to increased bone turnover, which is increased bone resorption and breakdown more than bone formation. Now, in the human body, there's what is called homeostasis. It's a way the body maintains a balance between breakdown and formation. So once this age is reached, the level of breakdown is higher than the level or the rate of formation. And that leads to weakness in the bone structure. And this particular type affects the trabecular part of the bone, which is the inner part of the bone, more than the outer, which is the cortex or the cortical part of the bone. Then there is type 2, part of the primary, that is senile osteoporosis, which is due to aging. And it affects both sexes equally and predominantly affects the cortex more than the trabecular part of the bone. Then there is secondary osteoporosis, which is caused by an underlying medical condition. There is also the classification based on severity on clinical assessment using clinical tools like FRAX score and measuring bone mineral density when you do tests like what we call a DEXA scan. Next slide. What are the risk factors for developing osteoporosis? What are the risk factors? One is being a female. So age is one. As you get older, we know that the level of your hormones, especially the male and the female sex hormones, the estrogen and testosterone, begins to drop, and that affects your bone mass and bone formation, as we have seen from the second type 2 or primary osteoporosis, which is senile osteoporosis. Being female also exposes you to increased risk because with menopause, there is more than usual drop from what we saw earlier on. Following menopause, you begin to lose bone mass by 2% per year. If you've got a low body mass index, which is simply saying when you're very thin, due to maybe eating disorders and other things like that, it increases your chances of having osteoporosis. Family history of osteoporosis increases your chances of having osteoporosis. History of a previous fracture or previous fragility fracture anywhere increases your risk of having osteoporosis. Long-term steroid use for medical treatment and also for use that is not medical could lead to osteoporosis. Medical conditions that leads to excess hormones in your body. Hormones are chemicals that are released in the body and helps in body metabolism, the functioning of your body. Some of them in excess could lead to osteoporosis. Drinking alcohol excessively will lead to osteoporosis. Smoking increases your risk or your chances of having osteoporosis. And some medications, like anti-epileptics, some medications used to treat heart failure in the past, which has been discontinued now, largely discontinued, could increase your risk of osteoporosis. Your ethnicity has a role to play. Osteoporosis is one of the diseases, thankfully, that is less common amongst Blacks. Osteoporosis is commoner with the Caucasians and the Asians, following in that order, the Latin Americans, and the Blacks. There are also abnormal bone conditions that could lead to osteoporosis. People that are born with genetic problems with their bones. For example, osteogenesis imperfecta is the big name, but it is a condition that leads to excessively brittleness of the bones that from when they are very small, they have broken bones all over without any trauma at all. Reduced physical activity increases your risk of having osteoporosis. Frequent falls also increases your risk. And some other medical conditions. Next slide. These medical conditions include rheumatoid arthritis, which is quite common, and other inflammatory arthropathies like psoriatic arthropathy, ankylosing spondylitis. These are names that you probably don't need to bother with, but know that there are other medical conditions that could predispose you to developing osteoporosis. Prolonged immobilization. If you typically have a sedentary lifestyle, you don't engage more in physical activity, then we talked about it earlier, whether for medical reasons or whatever, increased mobilization increases your chances of having osteoporosis. It is known that if you sit for greater than 9 hours, it increases your risk of osteoporosis by 50% compared to people that sit for less than 6 hours in 24 hours. We talked about hormones earlier on, overproduction or underproduction. It's interesting, and I think I should mention this here, because we know that diabetes is commoner amongst the Blacks, and diabetes is a predisposing factor to osteoporosis. Problems, medical conditions with your digestive system. Like celiac disease, Crohn's disease, ulcerative colitis, lactose intolerance, and chronic liver disease. All these increases your chances of having osteoporosis. Chronic kidney disease increases your chances. And post-transplantation. Post-transplantation of the kidney, especially, but others will have the same impact. There are also some gynecological conditions that predisposes you to osteoporosis. Untreated premature menopause, less than when you stop menstruating before the age of 45. And when you have prolonged periods of not menstruating, it's what we call prolonged secondary amenorrhea. And when your ovaries are the organ in the female that produces these hormones. So when they fail, it increases your chances of having osteoporosis, or any surgical removal of your ovaries, for example, due to other conditions like cancers, increases your chances of having osteoporosis. Then chronic obstructive pulmonary disease, which is a chronic respiratory chest condition that is common among smokers. It increases your chances of having osteoporosis. Next slide. How do we now diagnose and manage osteoporosis? If you recall that I said from the beginning that it's usually silent, it's a quiet disease. It doesn't announce itself until the damage is done. So how do we diagnose osteoporosis? One is to screen people above the age of 50 that have got any of the risk factors that we have listed. Any of the risk factors. Also, in the UK, for every adult that is older than 50 that's had 2 falls or more in a 12 months period, that's in a year, should be assessed. And the assessment can just be clinical, using clinical assessment tools like I referred to earlier, which is the FRAC score. And depending on that, a diagnosis can be made outright. There are some blood tests you could do also to monitor or to see the levels of the blood markers for bone breakdown. There are blood markers for bone breakdown. You could do blood tests for those as well. And the other thing you could do is a special kind of X-ray called a DEXA scan. That is how the diagnosis is made. Then how do you now manage osteoporosis? For patients that have broken bones, much younger in life, women less than 50 and men less than 75, they need to be further investigated to make sure there is no underlying and medical cause of secondary osteoporosis. Managing osteoporosis is both with non-medication and also with medication. Non-medication initially will be eating diets that are rich in calcium and vitamin D, and exposing yourself to natural sunshine, of course, with safety caution, especially using sunscreen so that you don't get burnt and develop some other complications due to ultraviolet rays, like cancer of the skin. We'll talk a bit more about the kind of diets that you could have that will be rich in calcium and vitamin D. There are medications for treating osteoporosis, starting with nutrition or supplementation. If you are not taking enough vitamin D or calcium orally through your diet and from sun exposure, then it's recommended that you should have nutritional supplements of vitamin D and calcium. Then when you've gone past that, there are medications that we call the bisphosphonates. The bisphosphonate, the commonest in that group is alendronic acid. What these drugs do generally is to make your bones stronger. They get incorporated into your bone fabric and make your bones stronger. Okay. Bisphosphonate is one, and alendronic acid is a very common one in this group. Then, if for those that have early menopause and problematic menopause with a history of fractures in their families and all that, hormone replacement therapies can be considered. There are also other medications like calcitonin, teriparatide, that are used for very severe osteoporosis based on the bone mineral density classification. Then there are also newer medications, denosumab and romosozumab, which are newer medications for treating osteoporosis. Another way of managing osteoporosis is by increasing physical activity. We know that in the UK, the drive is to be physically active over a period of 2.5 hours in a week. We'll talk about activities you could do. Then obviously, sometimes there will be need to refer and to monitor these people that have osteoporosis very closely to make sure that, one, they are compliant with treatment, that they are taking their medications and treatment as prescribed or as expected, and also to make sure that the treatment is actually working. Because in the management of osteoporosis, there's what we call treatment failure. The trust and the drive for most of us, geriatricians and autogeriatricians, is to try and prevent the first fracture. Because there's enough evidence to show that if you are able to prevent the first fracture, you may prevent fracture for a lifetime. For someone that has had a fracture, a fragility fracture, the chances of you having another fracture is highest in the first 1 year following your index event, following your first fracture. Okay. Next slide. How do we prevent osteoporosis? We talked about taking regular exercises to keep your bones as strong as possible. Aerobic exercises that would work on your stamina, about 150 minutes per week. You should also do some strengthening exercises where you try to increase the tensile strength of your bones and muscles by carrying weights and all that, but not very heavy weights. We're all talking of medium or moderate exercises. Then you need to work on your gait and balance as well, because problems with your gait and balance affect or increases your chances of falling and therefore increases your chance of having osteoporosis. We talked about healthy diet, and the foods that are rich in calcium and vitamin D include leafy green vegetables, dried fruit, dairy products such as milk, cheese, and yogurt. For vitamin D, you have oily fish, such as salmon, sardines, herring, mackerel. Red meat is rich in vitamin D as well. Liver, egg yolk, fortified foods. Fortified foods, you can have them. It's not really encouraged because it's not cost effective to use them. Some cereals, breakfast cereals, are now fortified. So if you can afford it and you want to have it, you can have it. We've talked about supplementation earlier on. So supplementation is another way of preventing it. Lifestyle changes is another way, which is giving up smoking if you're a smoker. And if you drink alcohol, reducing the amount of alcohol you drink. We know that for women, it is advisable to drink less than 14 units of alcohol per week. And for men, it's 21 units of alcohol. But generally, for you to prevent osteoporosis, it's advisable you don't drink more than 14 units of alcohol in a week. And that 14 units of alcohol is equivalent to 6 pints of average strength beer or 6 minimum glasses of wine. Next slide. If you already have a diagnosis of osteoporosis, next slide, please. If you already have a diagnosis of osteoporosis, anything that would affect or increase your chances of having a broken bone if you have a fall should be avoided. You should make sure your environment is free from every trip or fall hazard. Loose carpets, slippers that don't grip, or shoes that don't grip, that don't have good grip on the floor. Having your cables and electrical devices hanging around is not a good thing to do, because that increases your risk of falling and having a fracture. You make sure that your sight, your hearing, and your senses, what I mean your senses, your sensory feelings, your ability to feel, your ability to feel a touch, feel pain, feel warmth, especially in your extremities, your legs and your arm, is regularly checked, especially for people that have medical conditions like diabetes that could cause peripheral neuropathy. Taking your medications, including painkillers, and your treatment for osteoporosis is important. Exercises by way of either organized physiotherapy or you doing yourself exercises is also important. It's important you learn relaxation techniques and ways of distressing yourself, because stress in itself is not a good thing. Engage your health professionals is another way of dealing with them. Engaging with them will include you going for your usual checkups, either with your GP or your specialist. And in the UK, I know there are peer groups and support groups by the Royal Osteoporosis Society and other similar groups. Next slide. That brings me to the end of this topic. I'm sure there will be questions, and there may be areas where people will need more information. Thank you very much. You can fire on with the questions. Thank you.
Thank you so much, Dr. Idoye. It's been a tour de force, very interesting, a very in-depth look at everything with regards to osteoporosis. I know that I have, made some notes, and there's some things that I'm going to be able to implement in my life and my family, and I'm sure everybody else got some value. So, for time's sake, we're going to go straight through to the questions. Let me just get my. Okay, thank you. So the first question is, can osteoporosis be hereditary, and should individuals with a family history be more concerned? I think you touched on this in your talk.
I did touch on it. One of the risk factors is family members having osteoporosis, especially parents having fragility fractures. Yes, it can be hereditary.
Yeah.
So you need to be more careful. And if those are part of the risk factors that will necessitate your screening by the time you begin to get to that age where it becomes a real problem. Yes.
Fantastic. Thank you. I mean, I think some of these questions are probably because people may have joined the session late. So there's a question about risk of osteoporosis for Black people. Is there an increased risk? I think you addressed that. I'll let you answer.
Like I said, thankfully, osteoporosis is one of the conditions where the Black race seems to have a fairer deal.
Yes.
So yeah, we are the bottom
We've got
of the
one.
Road. Yeah, absolutely.
No
yes,
problem.
we have one.
Okay. So another mention, I'll answer this one. Thank you for this talk. Will there be a recording? So absolutely, there'll be a recording. These sessions are live streamed on YouTube and available on the Khan YouTube page. So either Sandra or Sam, if you can put the place for people to access the Khan YouTube page in the chat, that would be really, really helpful. And we really need people to support this. So the Instagram page, the YouTube page, please like and share these things because we need them in our community. Okay, another question. Are there a particular types of vitamins that maintain healthy bones? Again, I'm pretty sure you've addressed this. We'll just for time to go through that. Vitamin D is one, and you talked about like there are foods that are
rich in vitamin D and
exactly.
calcium.
So some of these questions, if you have a look at the recording, that'd be really, really helpful. Another question: is it accurate to say that women with larger hips are at higher risk of developing osteoporosis, or is it simply a misconception? Let's just myth busting.
I haven't seen any study to show that women with a larger hip I haven't seen that. Seen that. And I think it's more of a misconception. I mean, if you need to look at it beyond the science, women that have larger hip are actually African and of African descent.
Yes.
So if osteoporosis is less in Africans and African descent, then I would suspect. But like I said, I haven't seen any study.
Yeah. I think the data suggests that the issue is just women who are postmenopausal are at higher risk because the estrogen.
The hormone, and that has nothing to do with the size of the hip.
Hips, yeah. Okay, fine. Somebody had a hand up. Are they still there?
Oh, yeah, I saw someone that I saw a question. The place of is it mental stress?
Yeah. Okay, so how much does stress contribute to osteoporosis, and is it a chronic factor? Can acute stress precipitate osteoporosis? After this, we'll go to Faye.
Okay. Now, if you understand how stress works and the hormones that are released following stress, some of those hormones are akin to the steroids we talked about. So if you have them in a high quantity or amount in your system over a long period of time, then it will increase your chances of having osteoporosis. And that is why when I talked about preventing it, one of the things I said is finding a way to distress yourself. Find a way of distressing yourself. It does contribute to osteoporosis, yes.
Amazing. Thank you so much. Faye, I've asked you to unmute. Are you able to unmute and ask your question?
Yes.
Wonderful.
My question is there a link between osteoarthritis and osteoporosis?
Now, every disease, the direct link established is rheumatoid arthritis and the inflammatory arthropathies. That's established. But everything that affects your mobility and your gait indirectly could lead to osteoporosis. And we talked about it. If you have osteoarthritis that is debilitating and leading to immobilization, either due to pain or the deformity of the joint, then it could increase your chance of having osteoporosis.
Thank you.
Thank you so much for your question, Faye. And it's the more and more you have, because I think there's a need for specialists, for people who are experts in this in specific areas. But the more and more you practice medicine, the more you realize that the body is linked.
Absolutely.
And I believe that's how God created it. And my personal view is that's the reason why he calls the church the body of Christ, because we're all linked together. We need each other to be able to work in the optimum fashion. Anyway, enough of that. So another question. So person says, my dad is 86 and has reduced some centimeters in his height. How can this be managed as he struggles to stand upright?
I'm afraid from that only, I can say almost certainly that he has already some spinal fractures. Okay. Now, this is where, somebody was, I think one of the things nobody asked about it is the health deprivation. I didn't want to talk about it unless someone asked about it. When you have these things, I discovered that most of us Blacks, we don't engage with the system. You have to engage. See, deprivation is enhanced or encouraged when there is no engagement. We don't see these doctors. It's a minor pain, it may disappear. Then 1 week, 2 weeks, it's not disappearing. You lost height. You need to get it checked out. Another thing, for us, I tell my patients, it's one thing to see your doctor, but it's another thing to ask your doctor questions.
Yeah.
Black patients don't ask questions. You tell them everything and anything, they accept it. So that's why it's important that we get information, get ourselves informed, so we can ask questions. So for me, how do you manage it? You need to make a formal diagnosis, and making a formal diagnosis will mean getting your doctor to either see this patient or getting your doctor to refer this your dad to the geriatric services wherever you live. As long as it's not an acute pain that will necessitate him going through ED, such referral will be the next portal or the route. Then obviously an X-ray will be done, which in most cases is good enough in picking up spinal fractures, because compression fractures are almost picked in a high percentage with just a plain lumbosacral X-ray, depending on where it is. So once that is done, unfortunately, the bone is broken already. So we now have to manage the rate of deterioration by doing the things we talked about, using the medications and him being more active, taking the vitamins and all the rest of it. And of course, painkillers.
Thank you very much. Thank you very much. So a question we had from Grace. Thank you for this question, Grace. What are the side effects of medications denosumab and remozumab? Before you answer, Dr. Idoye, I think it's worth saying, because in my experience is that in some people, I'm not saying this is you, Grace, there is a apprehension about taking medication. And so anything that you said, okay, that's enough, I'm not going to take it. So we have to understand how side effects are reported. So when a trial is being done, any effect other than the effect that is desired is recorded. And the thing is difficult to pick apart is whether this thing is because they took the drug or happened at the same time that they took the drug. It also doesn't mean that because you take the drug, you are going to get side effects. So I think it's really important for us to understand how the evidence is being presented. I thought it's worth me saying that before you answer.
That's fine. Thank you, Ayo. Now, the other thing I want to say, even before answering the question, is this. Each time I do talks and they ask about side effects, you see, I want to put it back. What do we do that doesn't have side effects?
Yeah.
Anyone tell me? Tell me one thing that doesn't have side effects. You drink water, just drinking plain water, you can have side effects. It could go the wrong way. And there's also, the day I talked about it, and I said there's what we call water intoxication. and the person was like, water intoxication. I said, yes. If you haven't heard about water intoxication, then go look it up.
Yeah.
So there is almost nothing that doesn't have a side effect. So you understand that in taking medications is a natural, normal trade-off. You need to make room for some of those things to happen when you know that the benefit that you hope to achieve by taking those medications far outweighs those side effects. Okay. Now, the common side effects with starting with alendronic acid, which we would warn patients about and tell them to report when they begin to have such. And of course, some of them are actually contraindications. I didn't want to go into that in depth, one, because of our time, and I don't know the audience we have. Now, if you have things like active gastroesophageal reflux disease, gastritis, or ulcers, that is no for oral alendronic acid or bisphosphonate. Sometimes, if it's just mild, it's recommended that you can try another one. Apart from alendronic acid, you can try risodronate, which is risodronic acid. Then that is milder, but then be sure that it still causes it anyway. So if you do have it with that, then alendronic acid is not good for you. Okay, then you may do well with injections because there are injectables, bisphosphonates. Okay. The other thing is this: apart from upper GI, there are risks that you should know of if you are on alendronic acid. One is atypical fractures of the bones. It's a bit ironical that alendronic acid and bisphosphonates are supposed to make your bones stronger. Yeah, but they also cause atypical fractures, especially of the long bone of the thigh or your leg, which is your femur. And of course, when you are on these medications and you begin to have pain without any trauma, you need to get it checked out. Okay. Then the other one, which we always talk about, is osteonecrosis of the jaw, which is not very common, but it does happen. And if you have a poor dental or oral hygiene, even from the outset, you probably will not be giving bisphosphonate, especially injectables, because obviously your doctors will be very careful. But of course, if you choose to go ahead with it, fantastic, but you need to be closely watched. Those are the common ones for alendronic acid that we need to talk about. There are so many others, like I said, that we didn't bother with. Talk about denosumab and all those ones. Denosumab is reasonably tolerated, but they could cause things like flu-like symptoms, mild fever, but usually nothing major comes with those ones. No, we don't have any big issues with those.
Thank you very much. Thank you very much. Thank you, Royal RCCG Royal Christian Center. They said thank you very much for an informative session, Dr. Idoye, much appreciated. We've also got thank you very much, Dr. Mike, for such an informative session. Somebody thank me. Don't thank me. I'm just the host.
You are part of it. You deserve it.
It could have been anybody here. So I mean, I appreciate it, but I haven't done much here. Vitamins tend to have subtypes like D3, etc. Is it all vitamin D that targets healthy bones, or a particular type of vitamin D?
I think for someone that has functional gut system, any vitamin D you take will metabolize by your body to the active form. It's only when you have some conditions when your body is not able to metabolize, convert them to the active form, that it becomes necessary that you take certain types of vitamin D.
Fantastic. And again, I think this is, as Dr. Idoye mentioned, anything that we talk about in these sessions is broad strokes. You know, somebody could spend a whole day talking about the nitty-gritty of all this kind of stuff. So some of it, again, also as we mentioned, one of the things I keep encouraging our community to do is informed is armed. There are reputable places that we can go to make sure that we educate ourselves, so that we can take our responsibility for our own health. So just like as we mentioned, when you go and speak to your GP or your specialist, ask questions. Why?
Yes.
You know, it's I find it funny that when people come and speak to me, oh, the doctor said everything's fine. Like, what is fine? Like, what is fine?
What does it mean?
Exactly. Yeah.
What does it mean?
Exactly.
The
So
doctor said
we
it's
would.
fine. And I went to see the doctor, and this is the diagnosis. I said, okay, so what does that diagnosis mean? What does it mean?
Exactly.
Oh,
Yeah.
well, I don't know.
Yeah.
Excuse me.
Yeah.
Your doctor.
So we would both encourage you to just have just a little extra curiosity.
Absolutely.
The issue isn't about trust. The issue is about responsibility. This is your health. This is your life. This is your body. So it's really important to make sure that you take responsibility for it. And us as doctors, we are here to partner with you so that you can be as healthy as you can be. Another question is, can a collapsed disc cause osteoporosis?
Collapsed disc in itself will cause pain, debilitation, and reduced mobility. And by causing all those, especially in the spine, can also cause osteoporosis. Everything that makes you not reduces your level of activity, yes, can cause osteoporosis.
Wonderful. And again, I'm sure this question was answered if you want to go back to listen to the recording. But as a female approaching perimenopause, are there any advice apart from the ones already spoken about, example, supplements in the diet, that can reduce my risk of osteoporosis post-menopause?
First, we'll start from the risk stratification and risk assessment. You know, if, for example, you have no family history, you've not broken any bones, menopause happens, and people live through without having osteoporosis. Now, if you have any of those risk factors, and you know, for many of us, I think I have to say this, for many of us that are not taking active interest in our health, especially when it comes to bone. Okay, I hope most of us know that following the studies done even before COVID and with COVID, the role vitamin D plays in our body metabolism. And more so, the fact that because our skins are darker, especially those of us that are in this temperate environment, our skins are darker. The kind of sunshine that we will be exposed to in Africa that will make us produce enough vitamin D that we will not be deficient, we don't have it. For your skin, the dark skin, to produce vitamin D from the sun, you need to expose yourself a lot more. I think there was a study that was done by the osteoporosis and got some black and some white people. White people spending 10 minutes in the sun already had the expected level of vitamin D. But for blacks, they needed to spend at least 1 hour or more in the sun. So we need to do things actively, knowing who we are.
Yeah, absolutely. Especially on a day like today.
Yes, it's sunny. So yeah, go spend some time out in the garden or go to the park.
Absolutely. I read a study that mentioned about physical exercise and weight training in people over 70 and 80. And the interesting thing is that it helped increase lean muscle mass.
Yes,
and that's one thing that you can do to reduce the risk of osteoporosis from the falls point of view. But also, the interesting thing is another study mentioned that exercise is one of the things, in fact, it's probably the thing that as you get older, that's going to help you from a cognition point of view. All these brain training things you're doing on the phone, all of that is nonsense. You know, physical. You alluded to it before. In a lot of the communities that we come from, and we've been privileged to see our grandmothers and aunties and uncles and fathers who are old. In general, a lot of these people are very active up until the very, very end, and there's a reason for that. Question: I am postmenopausal and I'm currently taking multivitamins for 50 plus. can I get sufficient intake of calcium and vitamin D from this? If I may answer. So I think the first thing to remember is that a lot of these people who are doing these things, they're trying to sell you something. So that's the first thing to remember. Number two is that there are reputable NHS and WHO websites that will tell you how much you need, because you can then look at the label and say, well, this is only giving me 5 milligrams, 100 milligrams, and maybe you need 1,000. So then you can answer the question for yourself. Actually, a lot of this stuff doesn't necessarily give you the amount that you need if you are deficient. And I think lastly, it's possible to have a conversation with your GP, because GP can arrange blood tests and stuff, and they'll be able to. So as a doctor, if I'm prescribing, let's say, folic acid or vitamin D, I know that the strength of the medication that I prescribe is powers of 10 more powerful than the ones you can get over the counter. So if you really need it, often the things you get over the counter aren't strong enough to be sufficient if you have a problem in that area. Did you want to add anything?
Yes, the only thing I'll add to that is this. Supplements and supplementations are good, but I think the first thing is doing the first things first. Make sure your diet is rich. Good diet is a first place to start. Your diet being rich is absolutely necessary. Getting involved, engaged in the activity that exposes you to natural sunshine is another thing. It's only when you're not having enough of these that supplementation becomes necessary. And like Ayo said, there are standards. For example, for vitamin D, most of the ones on the market will probably have it up to, because usually it's just 10 micrograms of vitamin D that is recommended, except you are now going beyond supplementation to treatment, where you begin to talk of hundreds of that. So something around 10 micrograms will suffice.
Fantastic.
But then naturally, getting it naturally, sunshine food is the best.
Absolutely. Yeah. Absolutely. I saw a meme the other day, and it had a picture of vegetables, and it said, "This is what your pharmacy should look like." I believe that was God's intention. To put all of these things at our fingertips so that we could take care of our bodies in the way that was designed. Okay, absolutely. So if you're taking bisphosphonates, what is the best way to prepare for dental extraction? Your dentist will have some input. What can you do?
Now, dental extraction is actually different from dental hygiene. So you can actually go for extractions when you are on hyaluronic acid without any problem. Without any problem. As long as following the extraction, you follow through with all the advice that you are given. Make sure that you don't allow food debris in your mouth after a meal and things like that. And if you didn't have any problems with your dentition by way of poor hygiene, then you should do well. There isn't any strict thing by guideline that your dentist must do for you to have an extraction if you're on bisphosphonates.
Fantastic. There's a question from Elsie. It says, what medications are best for pain relief? I really think that it's very broad.
It's very broad.
And, I think the answer really depends on a lot more information than we could address in this session. So either, Elsie, our advice is if you want to, contact Khan and speak to, one of us individually, or maybe have a conversation with your GP. That it's a very broad question, and we wouldn't want to, misrepresent the information to you.
And the other thing to say, when you say what's best, it's difficult to say what's best, because what works for one may not work for B. What works for one condition may not work for the other condition.
Absolutely.
So getting the appropriate health personnel to follow you through that journey of pain management is important. Suffice to say, there's what we call the pain ladder in pain management. So there are so many
Exactly.
things. There are so many things.
Yeah. Absolutely. And again, many thanks, Dr. Idoye, for a powerful presentation. I had a question. So somebody who has diagnosed osteoporosis, so
Yeah.
before fracture, they've got
Yeah.
diagnosed osteoporosis. These interventions that we're talking about, so they change their life around,
Yeah.
they start physical exercise, they're much more intentional about diet and sunlight. Is
Yeah.
there evidence to say that their frac score changes, or they're also, or what you would get when you would do a DEXA scan?
Yeah. The FRAS score changes, the DEXA scan changes, and the blood test that you do to monitor bone resorption also changes. And that is, by doing that, is how we would know if the patient is responding to that treatment, and that leads to the failure of treatment that I talked about earlier on.
So I think it's really important, because sometimes with these things, one can, if you're not careful, one can lose hope that, oh, I have this thing now, and I believe that it's possible. What we're saying is that even if you've been unfortunate enough to develop osteoporosis, or these things have happened as a fracture, it is possible, whilst you still have life, to change things, to course correct, to strengthen your bones, to give you as much function as possible. And these things are, again, back to you taking responsibility for your life and you. So thank you so much. Is there any last nuggets that you want to drop us with before before we hand it over to Sandra?
I think for me, it would just be take responsibility, look after yourself, be intentional in what you do, be very intentional. I remember the first time I took my vitamin D. I'm a doctor. I work in the hospital. I know some of these things. In 2017, I discovered I was just, my level was 40 something, less than 50, which was recommended. And I took action, and thereafter it's been okay. So you could be carrying on well, looking seemingly, and some of these things are missing. Get checked out. Do your blood checks, your usual. Above the age of 45, you want to do it. I mean, if your GP doesn't ask you to do it, you ask for it, and get it done. And take responsibility.
Wonderful.
Thank you.
Wonderful. Thank you so much, Dr. This has been a very informative, educational session. We're very, very appreciative of your time and your expertise. I'm going to hand over to Sandra. Thank you so much, Sandra.
Thank you. Thank you so much, Dr. Michael, for a fantastic and insightful session full of valuable information. And thank you, Dr. Ayo, for hosting and moderating today's session. We are extremely grateful for your time. Just a few announcements on our upcoming events. Sam, can you please share the slides? Okay, so next week we will have another interesting and engaging discussion on mobility and falls in older age. It's same time next week between 11 to 12:15. Our guest speaker is Reverend Canon Dr. Patrick Anochi. So please invite your friends and family as we learn more about this topic. Next slide, please. Another interesting program to tune into every Tuesday is our Healthy Hearts program. This program is focused on nutrition and healthy lifestyle, as well as a physical exercise session with our physical trainer. This Tuesday, we'll be discussing complementary feeding. This is a very interesting topic for those who are concerned about how to feed their baby after 6 months of exclusive breastfeeding. So please join us on Tuesday at 6:30 p.m. and email us at events@can.org.uk to register for the event. We have available a culturally appropriate family and advocacy service. We would like you to know that during tough times, you are not alone. So if you would like to access the service or know of anyone who needs some crucial support, then kindly give us a call or email us at help@can.org.uk. Are you passionate about tackling racial inequality and shaping policy? If you are, then you'll be interested to know that the GM Race Equality Panel is recruiting and applications will be closing on 10th of September. To apply, kindly follow the link on your screen. Next slide, please. CAN is celebrating Black History Month again this year, and we would like to invite you all to join us as we celebrate our sisters from the Windrush era. We want to recognize the 75th anniversary of the arrival of these brave Black women from the Caribbean to Britain and honor their legacy. We will be joined by keynote speakers, including Professor Elizabeth Aniowu, Andy Burnham, the Mayor of Greater Manchester, Christian Weaver, and Charlotte Norman. There will be loads of activities on the day, including live music, interactive cultural entertainment, information stalls, and Caribbean and African food. Entry is free, so please join us on Thursday, 28th September at the Manchester Cathedral from 6:30 to 9 p.m. There is also the opportunity to book a stall and promote your business or organization at this event. For further information and to book a stall, please email us at events@can.org.uk. Our 6th anniversary and annual fundraising gala is here once again. We would like you to join us for another unforgettable night as we celebrate individuals and organizations who have greatly impacted the health and well-being of the Black community in the UK. The event will take place at the Lancashire Cricket Club on Saturday, 28th October from 6 p.m. until late. So please purchase your tickets. You do not want to miss out on this event. To register or buy a ticket, kindly scan the QR code or follow the link on your screen. As we celebrate our achievements, we want to also acknowledge our champions. As part of the gala, we will be revealing the winners of our prestigious awards, recognizing those who have made significant contributions to our community. Nominations are open until Friday 22nd of September. We invite you to submit your nominations by, again, scanning the QR code or following the link on your screen. For any inquiries, please, again, email events@can.org.uk. We would like to say massive thanks to our partners for putting this wonderful program together. A big thank you goes to Enfield Caribbean Association, Rafa International Development Agency, the Royal Assembly Redeemed Christian Church of God, Croydon BME Forum, and the Black Health Initiative. And we have their contact details on the screen. In closing, I would like to say a big thank you to Dr. Michael and Dr. Ayo for hosting today's session. For myself and the whole team at CAN, thank you so much for joining us today, and we look forward to seeing you again next week. Do look after yourself and enjoy your weekend. See you soon. Bye-bye.
Improvement Program, CAFIP Health Hour. The Caribbean and African Health Network, CAN, along with its national partners, are incredibly pleased to continue to bring to you health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell and many more. We have not forgotten to include within our health hours the many societal, cultural, religious and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you and we want you to use the time to listen, learn, share your experiences and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@carn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIB is funded by the National Lottery Community Fund.